Immunizes is supported by Iowa Public Health Association. Iowa Public Health Association is the nonpartisan, nonprofit membership organization of public health professionals and allies in Iowa. Together, they work to inform the public, educate their members, and influence policymakers on matters critical to public health. Our webinar is being presented by Dr. Richard Deming, Dr. Mustafa Eldada, and Dr. Timothy McCoy, all from Mercy One Des Moines. Thank you so much. The floor is yours.
Thank you so much. Well, good evening, everyone. Thank you for joining us, after your long day. I'm sure everybody had a busy day earlier. Today, I have the privilege to introduce two of my well-esteemed colleagues, Dr. Richard Deming. He's one of our radiation oncologists at Mercy One Medical Center. He finished his medical school at Creighton University, followed by his radiation oncology residency training in San Francisco, California. And also introducing Dr. Tim McCoy, who is a very well-known family medicine doctor for many years here in Des Moines area. He finished his medical school at the Des Moines University, followed by family medicine residency at Iowa Lutheran. And just to introduce myself, I am Mustafa Eldada. I'm one of the pediatricians at Mercy One Medical Group here in Des Moines. We appreciate you being here with us. I would start with our objectives today. We're supposed to review the HPV in general, including Dr. McCoy's presentation about HPV 101. Also have some explanation about the vaccination rates, and Dr. Deming will talk to us about the cancer burden from the HPV infection. And Dr. McCoy will talk to us also about the announcement approach about HPV vaccination, which is something I feel it's very important for us to know how to introduce that concept in our clinics to talk to families about the vaccine. None of us have any financial relationship with any pharmaceutical company or anybody else, so that's just like routine disclosure. I will basically start the whole presentation with this nice Iowa map showing our counties with the rate of vaccination. This is from the Iowa Department of Public Health. You can tell from the color, like the dark blue with higher vaccination rate and the very light one with lower immunization rate. So please look at your county, wherever you are practicing, to see what's your rate roughly. Hopefully that will give you some feedback about what else we need to do. And with that said, I will pass the slides to Dr. Deming. At the end of our presentations, we're going to have some time for questions and answers. You can ask directly, or you can do it as a message. So with that said, again, I will pass it to Dr. Deming.
Hi, thanks, Mustafa. Again, I'm Dick Deming, and I'm a cancer doc. And the reason that we have a cancer doc talking is there would be no need for HPV vaccines if HPV didn't result in cancer. So unlike many of the other vaccines that we have in the United States and around the world that are designed to reduce the likelihood of an acute illness due to a virus or a bacteria, we have HPV vaccines because HPV causes cancer. And so what I want to review with you is not the information about the vaccine itself, but how and what cancers are caused by the human papillomavirus. There are 6 different cancers that are caused by the human papillomavirus, and we'll talk about each of these separately. You can see all of them listed here: cervix cancer, vaginal cancer, and vulvar cancer in women, penile cancer in men, and then anal cancer and oropharynx cancer, and we'll talk more specifically about that, can be in men or women. So those are the 6 cancers that are caused by the HPV virus. How does HPV cause cancer? Well, the HPV infects the cells and it interferes with the way that these cells communicate with each other. So what a cancer cell is a mutated cell that no longer behaves nicely in the sandbox. Normally, when a cell comes in contact with its neighboring cells, it understands that it doesn't need to continue to proliferate. But when the HPV gets into the cells, it affects the ability for the cells to regulate their own growth. And it also affects the immune system in that environment and leads to the mutation of a normal cell into a cancer cell. Again, we're going to talk about the 6 different cancers that are known to be caused by HPV. The most well-known in the public is cervix cancer. So the cervix is the bottom part of the uterus. It's the last part of the uterus that a baby would come through at birth. It's part of the birth canal. When a woman goes in to get a Pap smear, the physician is actually scraping off some cells from the cervix, the lowest part of the uterus that's up at the top of the vagina. And this is a screening test to look for abnormal cells that could be caused by cancer. And nearly 100% of cervix cancers are caused by the HPV virus. An even more common HPV cancer that the public doesn't know about as much is Oropharynx cancer. And the oropharynx is the part of the throat that you see if you open your mouth and look in the mirror way back at the throat. It's the part of your throat where the tonsils are and where the very back of the tongue, we call that the base of the tongue. So it's not part of the mouth, not part of your cheeks or the tongue, the tip of the tongue. It's way back in the throat. That is the oropharynx. It used to be, before HPV became so prevalent, that the only patients we would see with oropharynx cancer would be individuals that had other risk factors, such as cigarette smoking and alcohol consumption. Now, about 70% of oropharynx cancers are caused by HPV, and we often see them in individuals who don't smoke or drink at all. Again, 30, 40 years ago would be very rare to see an oropharynx cancer in someone who didn't have smoking and alcohol consumption. Now it's very common to see highly educated individuals who don't smoke and drink who have oropharynx cancer. The third type of cancer is anal cancer, and over 90% of all anal cancers are caused by HPV. So the anus is the very lowest part of the digestive system. It is just the inch of the lower part of the digestive system right above the anus. That also is a squamous cell carcinoma. I should say that another thing that all of these cancers have in common is the histologic type of the cancer is squamous cell. That is the type of histology that covers the skin of the body, the mouth and the throat, and also the lower part of the digestive system and the vagina. The fourth type of cancer is penile cancer. Penile cancer is very rare. Even though HPV is very, very, very common, the chances of developing a penile cancer is exceedingly rare in the United States. For men, the most common HPV cancer is the oropharynx cancer, cancer back in the tonsil region. For women, it's the cervix cancer. But for some reason, even though the HPV virus is spread by genital to genital contact and also oral genital contact, in men, they're much more likely to get an oropharynx cancer caused by HPV, and women much more likely to get a cervical cancer caused by HPV. The last 2 types of cancer caused by HPV are both in women, vaginal cancer and cancer of the vulva. The vulva is the outer part of the introitus of the genitalia of a woman. It's really where the skin comes together right at the opening of the vagina. That's the vulva. And again, almost 70% of oftentimes with oropharynx cancer, it will spread into the lymph nodes in the neck. The picture on the right, you can see kind of a bump on this guy's left neck. That is an enlarged lymph nodes, and it's very common that someone who has oropharynx cancer may not appreciate that they have cancer in their tonsil until a lymph node swells up, and that's what prompts them to seek medical attention. This slide shows the new cases that we're likely to see in the United States caused by HPV. You see in women, that's the circle on the left, and the green at the bottom, 11,000 new cases of cervix cancer caused by HPV in the United States in a year. And you can see that there's actually more oropharynx cancer in men than there will be cervix cancer in women. And the circle to the left are the distribution of the HPV cancers in women. Cervix dominates, oropharynx, vulva, and anal are next, and vaginal cancer is rare. In men, oropharynx is 80% of HPV cancers in men are oropharynx. Very small number have penile cancer, and a very small number will have anal cancer. When we look at the impact, what I want you to look at here is that middle column with percentages, and those are the percentages of the cancer that is actually caused by the HPV. So some cervix, vaginal, penile, anal, oropharynx cancer are caused by other things, but HPV is the predominant, and in cervix cancer, anal cancer, and it's over 90% of those cancers are caused by HPV, and a very large percentage of vaginal, vulvar, penile, and oropharynx cancers are caused by HPV. Definite, the dominant risk factor in all 6 of those cancers. This shows you the HPV-associated cancers and the age of diagnosis in women. So the blue that peaks early, that is cervix cancer. Cervix cancer is much more likely to occur at a younger age. The red is vulvar cancer. Vulvar cancer is much more common to occur in older women. And in fact, when you look at that line, the older a woman is, the more likely that they may develop vulvar cancer. When we look at the age distribution in men, we see that, again, oropharynx cancer is the dominant, and it tends to peak at about age 60 and then declines after it. Again, penile cancer and anal cancer are small in comparison to the oropharynx cancer. This just shows you the same information with different graphics, looking at cervix cancer peaking at age 49, and the other types of cancers peaking at older age, with vulvar cancer probably being the oldest. Talk about a little bit about screening. Those are 6 different types of cancers caused by HPV. Only one of the 6 cancers do we have a verified screening test, and that is Pap Smears for cervix cancer. There is no good screening test for vulvar cancer, vaginal cancer, anal cancer, oropharynx, or penile cancer. So the only one of the 6 cancers caused by HPV for which there is a good screening test is cervix cancer. All the more reason to have a tool for preventing the cancers rather than having to screen for them after they've already developed. And the reason to do an HPV vaccination is HPV has been proven to prevent cancer. Now, in all honesty, most of the studies have looked at the prevention of cervix cancer. That's where the data is the most robust and the strongest, showing that you actually prevent cancers. We have no doubt that when all of the other studies mature, we will find that HPV vaccination not only prevents cervix cancer, but will prevent the HPV-associated oropharynx cancer, vulvar, vaginal, anal, and penile cancers as well. So HPV causes cancer. These 6 different cancers result in death, and vaccination can prevent cancer and prevent death. So I'll turn it over to the next speaker, and I think that's Dr. McCoy.
Yep. All right. Thank you very much, Dick. So hopefully everybody can hear me okay. Send a chat if we can't. So these are some discussions that I've had in the past with Mercy One providers. And so I see on the attendance list, there's a couple Mercy One providers. So this may be a little duplicative for some of you, but and I don't know exactly our audience tonight. I know Dick Deming is having some folks out at his cancer center out there tonight that are potentially cancer survivors. And so some of this approach of HPV vaccination is more focusing on, say, parents of teenagers and parents of 9-year-olds. So may not be quite there, but you probably have some grandkids in these ages, or some. I think this will be relating to everybody. So we'll go ahead and Dick and I are trying not to duplicate anything, but these are some things that these are some slides we put together with the help of American Cancer Society. And so these were some discussions I've given. I gave this talk, I believe, down in the Monroe County hospital area. I've done this with our Mercy providers here as well. So again, whoops, sorry, no disclosures there. Similar agenda that, like Dr. Aldada mentioned previously. Some I tried to not go over as much of the HPV 101 since Dr. Deming had gone through some of that, but I am going to talk about this announcement approach training and kind of what we did at Mercy One a couple years ago. It seems like an eternity ago because it was pre-COVID, and as we all know, pre-COVID really wasn't that long ago, but it just seems like forever. I saw in the chat some folks had asked about slides. So there's some HPV resources here from American Cancer Society that I'll share. Really a couple very powerful videos that American Cancer Society has put out. Probably about 3 or 4 years ago, I got involved up at an HPV roundtable, and some of the videos that we're sharing in these slides later are actually people that I met that were cancer survivors. And so very, very powerful in discussion. So these are some things that we will be talking about, and I think we have about 20 minutes to get through some of these, so I'll try not to go too quickly. These are some things that Dick had already talked about. Obviously, the vaccine is preventing cancer, and so we are not focusing on where the focus is on that, and not on sexual activity, not on those kind of things. So that's why we're focusing on that. Like Dick mentioned, I thought we didn't duplicate, but I guess we duplicated a little bit. Like Dick mentioned, 6 types of cancer, only screening is for cervical. So that is what Dick had just mentioned. A lot of folks are aware of Pap smears, like Dick had talked about. This is just some data of precancerous abnormalities that women have with Pap smears. So any women on the call know the procedure of a Pap smear, and this is some numbers of huge numbers of low-grade cervical dysplasia, millions of people, maybe not millions, but this, as this mentions, over 1 million women affected each year with abnormal Pap smears, greater than 200,000 new cases of high-grade cervical dysplasia, like Dick mentioned, with HPV or Pap smear testing, so precancerous. So yes, there's the cancer discussion, but also there is some of these precancerous discussions too, that we feel when we can get our HPV rates high as we want them to be. I'll share a little bit of some of the data, as well as Dr. Eldada shared some of your data, maybe in your counties, that we can make a difference with these million women that are having low-grade cervical dysplasia, Pap smears and LEAP procedures are not fun procedures to have, and so that's what we're trying to focus on. So there's a lot of studies about the safety of HPV. I know parents come up with a lot of different discussions about safety. Obviously, in our era of COVID, we all understand safety and COVID vaccines, but these were from slides. Dr. Noel Brewer was the doctor that talked about this announcement approach, so I got some of these slides from him. Some of these are a little bit old, from 17, but when I was giving these discussions, it was, like I said, pre-COVID. So hundreds of studies. This slide, I'm sure, is old by now, and this 2.5 million people in 6 countries is, I'm sure, much larger by now. And so we've not seen any serious side effects besides what is typical. I think all of us that give pediatric vaccines are aware that people can pass out, people have reactions, but safety is not an issue, and need to update this to see exactly how many more millions I'm sure this is since this slide was created. So vaccine schedules, these slides again were a little bit old, but because now the check mark here, as you can see, starts at age 11 to 12, but there are many societies that are now talking about vaccinating at earlier ages, even down to age 9. So American Cancer Society recommends the vaccination between 9 and 12. Our clinic system here at Mercy One is, when I was giving these talks previously, was probably focusing on that 11 to 12-year-old age. And so when I talk about the announcement approach later, what we do is we bundle the discussion, because at 11 to 12, they'll need 3 vaccinations. So if we are going to move towards that earlier age group, that 9 to 10, they don't need the other vaccines at that age. And so that may be changing. And we do know if we give the vaccination earlier, I think I have some slides a little bit later, the vaccine is more effective. We do know if we give the vaccines earlier, it's 2 doses. So if you see these 2 columns here on the left, it's 2 doses. And if we wait to give the HPV vaccination, it's 3 doses. So I have 4 children. If I'm going to tell them I may give you 2 shots versus 3 shots, they'll take 2 any day. And so something to think about from the timing of the vaccinations. So these are some rates. Again, these are similar to the first slide that Dr. Eldada showed. So if you can look, obviously we're in Iowa. Our rates are somewhere around this 70 to 79% with 1 vaccine. So completion is our goal. And so the first dose, as you can see when I share some of our data at Mercy One, first doses are obviously higher than the second. So we'll talk a little bit more about data in a couple more slides. So I think we're getting there from the new norm. I think we're, if we're hitting close to 70% of our adolescents are starting the HPV series. I'll share some of our numbers, like I mentioned here. Roughly 51% are fully vaccinated, so we're getting close. But some of our other data that many of you are aware of, our other vaccinations with meningitis and pertussis are over 80%. So we're getting there. I'm not sure we're there yet. So, finally, the new norm, I don't think we're quite there, but we're getting there, and I'll show you some of that data a little bit later. So this talks a little bit about about why we would do it at those younger ages, at that 9 to 11. We certainly have more chance to vaccinate earlier, as we all know. Our pediatric population, as they age, they come see us less often. And so if they don't, especially if in many of our communities, if they don't do sports, they sometimes aren't here. And so we have less exposure if we wait. And so as a 9, 10, or 11-year-old, we have more exposure to the patients, obviously more chances to vaccinate. And then, like I did mention previously, fewer doses for 2 vaccines versus 3 vaccines. So, again, may not seem like a lot to parents, but parents that have children, it's a big deal. An extra shot is sometimes a big deal. So, again, these are some things that Dick had already mentioned. Again, the 6 types of cancers, safety, effective, and we do know that we do have kids that are just not being protected. And so what we're trying to focus on is how can we increase the kids that are being protected. And so this is where we'll talk about a couple other things. There's been some studies, this again, a little bit old, but a very large predictor of vaccine uptake, of parents saying yes, is how the provider started the conversation. And so when I looked at our attendance list, I saw some providers I recognized, but so I'm not quite sure exactly if we have a lot of providers on or nurses on. I know we have some patients on, but how the provider started the conversation is very important. And in one of the videos that the American Cancer Society talked about later in the presentation, if we have time, I can play that. But it was a parent that talked about the conversation that her provider had, and that initial conversation is very important. And so if we lead with something like your child is required to get 2 vaccines of tetanus and meningitis, and the 3rd vaccine isn't required, but you can think about it, and that's HPV. So if we do that, of course, people are going to say, I'll take the 2 and I'll think about the 3rd one later. And so this particular study mentioned the best predictor is how the provider starts the conversation. And so this is where this announcement approach came from. Dr. Brewer had started this. And so when I gave these presentations previously, we actually did this in all of our family medicine and pediatric clinics. And we had front desk staff and nurses and providers. We would do some role playing. I'll go through some of this a little bit later. And so this predictor of uptake is not just by the provider, because I see on the chat there's a couple nurses that are here at Webster County, Johnson County Public Health, and so yes, it is. This slide mentions provider, but it's not just providers, and so this can start at the front desk. This could start with nursing, and obviously can start with providers. So this kind of just looks a little bit of this announcement approach. And again, this is from data previously, or not data, but the schedule previously when we would be discussing, say, 3 vaccinations. So if the provider doesn't recommend it, this study mentioned 23% will get the vaccine. If they kind of say, oh yeah, maybe you could, it goes up, and obviously higher than 75, nearly 3/4 will say yes for the vaccine if it's highly recommended. And so a couple key statements that we'll talk about later in this announcement approach is recommending it today, is recommending it in between, like I mentioned here. So when we did these role-playing exercises in our clinics, one person would be the patient, one person would be the parent, and one would be the provider. So an example of, we actually had people write down their little sentence like this mentioned here. So like this says, Molly needs 3 vaccines today to protect against meningitis, HPV cancers, and whooping cough. She will get those at the end of the visit. And so that's the announcement approach in a nutshell. You just say it, you stop, and just kind of pause a little bit. And that's kind of how we had started some of our education sessions. So a lot of barriers that we have to overcome. One of them obviously was the recommendation, like I mentioned. Obviously, like I mentioned, also with the 3 vaccines, if you're doing it at that 11 to 12, recommending it just like all the others. Again, if we're doing this at 9 to 10 or 9 to 11, that may need to change just a little bit. Like we talked previously, like even Dick mentioned, HPV is cancer prevention. And then after that, this is where, after this last bullet point, is where it sometimes gets a little uncomfortable for providers. We as providers, you have a busy day, you don't want to spend 20 minutes reviewing all this stuff. And this is where it gets a little bit tricky. You have to offer some empathy that you care about what they're saying. You can try to give some advice. Dr. Brewer had talked about some data that we can go through. And so these are some of the barriers that all of us have probably already had in the past talking about this. So these are not really new. And the first one, I did forget to mention that a little bit. There's some changes in systems and processes that can improve this. At the end of our slides, we talk a little bit about some evidence-based practices that can sometimes help improve this. Some of these I feel are more the second dose than the first dose for HPV, but we'll chat a little bit about that if we have time. So this is kind of, this was from 2018 to I believe 2020. So this is a little card that when I did these announcement approaches with providers, staff, schedulers, all these kind of things, this was documents that we brought. So, if clinics are interested in this, we can talk about this and do this, but the little card here talks about the 3 basic principles with the announcement approach: announce, connect, and counsel. And so, like I mentioned, there's the little bullet point, the little first little statement, because Michael's 11, he's due for this. So that's the announcement. You put the patient's name, you put their age, you put that they're due for this. They mentioned to bundle the HPV with the cancer in the middle. You don't want to focus one or the other on that. And so that's what this was mentioned. And say you'll vaccinate today and then just kind of wait and see what happens. And if the parent doesn't say much and you move on, then you go through the rest of your preventative screening stuff and all the other stuff that you talk about. But if they do hesitate or you pick up on nonverbal cues, these are some things that can help. So what's your main concern? Maybe repeat what the parent is saying. I hear what you're saying. So these are some things. So these are also on the box to the bottom left are some things that could maybe counteract maybe what a parent should talk about. So we talked a little bit about the dosing and the HPV vaccine being more effective at a younger age. So if you're talking to a parent of a 9-year-old that says they're too young, we can bring up here things like kids respond more strongly to when they're younger, better protection. The sexual activity thing is obviously there, but I think is getting to be less and less. Safety we talked about, effectiveness, guidelines of CDC or American Cancer Society are some things that we can talk about. This was more common right when we started with boys versus girls. Obviously, every one of us remember it was approved first for girls and then approved for boys, which wasn't the greatest plan. And so we kind of tried to work through some of that. And then we do mention also about the school requirements. Again, school requirements don't keep up with medical science. We know that with our experience with COVID. How many times were we arguing of school requirements for kids getting back into school with COVID versus CDC's guidance, or with our adult population? I don't remember how many times I was doing COVID tests in my clinic with patients that needed a negative COVID to go back to work, even though I knew it was not medical science. And so we're very well aware of that. And so this is this announcement approach kind of in a summary. Over to the right-hand side, we sometimes did some role playing. Obviously can't do that in a webinar. And so we actually would have a provider write down their statement. and then maybe potentially look at some messages of some concerns of hesitant parents. And then we did some role playing. Again, it was a little awkward, at times, but we went through that. And then obviously the parent can do the role playing the same way. So that's the announcement approach discussion. And I think most of these slides kind of go through it a little bit more. So again, I'm going to skip through some of these because the announcement approach, I wanted providers and nurses and folks on the call to be aware of it. I'm actually still working with Dr. Brewer in a study that we're going to be still continuing to look at this research. So again, this kind of was part of Dr. Brewer's discussions about provider recommendations that we kind of already talked about. Without a recommendation, 25% or somewhere around that, and that number obviously is going to go up closer to 75% with that recommendation. So mentioned that previously. Again, this is kind of slide for slide with this announcement approach. So again, I'm not going to go through all of this because we kind of went through that with that summary page. So again, if they do have a concern, what's your main concern? These are some examples. It doesn't seem safe. I understand that you're concerned about safety, and then you go through some of the data. So counseling is kind of what you would do next. And then lastly, after the counseling, I think the next slide talks about many times. Oh, sorry, this is more about hesitancy. So sorry, these are again those same tested things on that card. Again, good for your knowledge that we already chatted about. But what I was going to say was, eventually, many people do say yes, and so that's I think another couple slides. Sorry about that. So again, just as through the announcement approach, I just got to get through a couple of these. Just got to get through these. Sorry, we're running a little bit on time. Just a couple other things. There's some tips again. These all will be shared. This was a little bit of the follow-up after the initial no. Parents most do get to yes. This is where maybe some of your processes might be an issue. I was on a call just a couple of weeks ago with Dr. Brewer's team about some future discussions, and one pediatrician that I talked to, I think he was out in the Pennsylvania area, he actually sends a task to his nurse in 2 weeks and says, hey, Dr. McCoy mentioned you were in for HPV and you weren't sure about the HPV vaccine, and he wanted me just to circle back and see what your thoughts were. And granted, that may create some more discussion, but at least it tells the patient that you care, that you heard them, that you understand. Will they come in for a nurse-only HPV without an office visit? Probably not, but I think that was an interesting comment that somebody said. About half will get it later. Another quarter will plan to, and so this is, certainly you have to bring it up at the next visit. Sorry, slide. There we go. So this is some of the data that we did. Again, January of 19 seems like an eternity. So what I did mention previously was meningitis and Tdap in this purple columns on the far left are close to 90%. And so back in January of 19, our first dose completion was around 66% for females, about 61% for males. Again, still battling that whole males versus females with HPV. And then our completion rates were around 40% for females, as you can see, and about really quite low with males of 33. And so when we combine those on the far right, these were some of our data: 63% completion of the first dose, pushing 40% of completion, and still 90s of the other vaccines, typical given. So then what we did was, this is just a little bit of a summary, but then what we did was went through our announcement approach and our completion rates for combined went closer to 70. Our first dose was closer to 70. Our completion dose for combined was close to 45. And so this, I think, was a little bit of a summary. We had some of these increases to me were a little lower than I was hoping. 4% increase of females with first dose and 6% completion. 5% combination increase and 8% increase completion. But when I originally looked at this data, I was like, well, that seems kind of low. But actually, I think it was pretty decent. Last couple things on the slides here are some resources from American Cancer Society. And so there's a lot of documents behind all these things about some other evidence-based practices of other ways to increase your immunization rate. So I don't know if many of you have standing orders. I think we've not utilized those much at Mercy One. I think I'd like to potentially introduce maybe a second dose standing order. I think a standing order for a first might be a little bit difficult, but that might be something. Provider reminders. So this is where I talked about previously with processes making your changes. So I don't know how many of you as a provider, if you give an HPV vaccination, do you put in a reminder for the second one, or do you just wait till they come back? And so that's some other ways that maybe some processes can change. Client reminders and recalls, like we mentioned there. Well, these are some evidence-based interventions with American Cancer Society that you can look through. These are some of the resources. I think I might have time if I can make it work. I always never wonder how technology is going to work with this, but I think we'll probably have time for a video. So these are some videos over here. I don't think I can link to it. I don't think I can, but these are some of this Chris's message. If we could get that link, Chris was the wife of, I think, Steve or John, I can't remember which one it was, who had oropharyngeal cancer. And so I was at a conference, like I mentioned, up in Ankeny about maybe 5 years by now. And they were there speaking, and their son was there. I think maybe John might be the husband, and Steve might be the teenage child. And so some of these were very powerful messages about this. So hopefully we can get these to, it looks like Elizabeth is sharing the links there to those videos. So again, very powerful. I think, and the provider's recommendation was Chris's big message, because she shared in her video that, she goes every time before her child and her go to the doctor's office. The child says, what immunizations am I due for? And literally she mentioned that when she saw her provider, I don't know, who it was, but they mentioned that they said, like I mentioned previously, you're due for these vaccinations, and this HPV one you might consider, and so that shocking that was where we didn't get a big uptake in that. So those are some resources, and thank you for sharing those. And I think those are close to what we have. There's a couple more resources here. The American Cancer Society does put these action guides. I printed some of these off. These are actually ways that systems can try to make some changes. So these are all documents that the American Cancer Society has put together, and I believe that might do it for those slides. So I guess maybe a couple questions. I think we've got some questions that we can answer, and thank you for some links of the video. Thank you for putting that in there, Elizabeth. There's some links to Iowa Department of Public Health as well. So if anybody has anything to share, we'll share out those resources. But I think we are up to our question and answer. session. So Dr. Eldada, any comments from your perspective?
Well, thank you very much, Dr. Deming and Dr. McCoy, for this nice presentation. I think the information you shared with us is definitely very valuable. You know, knowing the burden of the cancer on individuals, I'm glad we heard about it's not only about cervical cancer, but learning about other cancers like oropharyngeal. I would say consequences. Number two, I think our experience with talking about the HPV vaccine to our families got much better compared to 2 or 3 years ago. When the vaccine first came to the market, we were somewhat also, I would say, not very knowledgeable about how to approach families. But that approach that Dr. McCoy is trying to teach us, I think it's a very practical way. It became part of our language. When we go to the room for all those patients at age 11 or 12, we say it exactly as simple as that. You know, the kid needs today the Tdap and the HPV plus the meningitis vaccine. So it became as a routine. But even the nursing staff, I would say they became much, much better talking about it. So thank you again for sharing with us that information. One more thing I may add to it. I personally, and most of our clinics, we learned one thing. When we give them the dose today, when they leave, we give them a small piece of paper to say, please schedule your next shot in 6 months. This way, we make sure that they will schedule before they leave the clinic to minimize the risk, like they go home and they forget about it. Granted, we may see them again in a year for their well child visit, but just in case they don't show up, that's another hint, probably. And part of the chat, I think one of the nurses mentioned something that she has a recall system. I think that's a very nice thing. I hope everybody can share with us their experiences. And with that said, please, let's go ahead and have some questions and answers now.
Please feel free to type any questions into the chat box. If you feel more comfortable, you are welcome to unmute your line and maybe even open up your video if you want us to see you and ask some questions live as well. So we'll just leave a few minutes for that.
Yeah, I liked David Thomas's comment about hesitant teen boys. Vaccine presents penile cancer, and one of the treatments is to cut off the penis. That's a good one. That's got to be evidence-based there. So that's that's pretty good. Looks like a couple of people are doing the scheduling the nurse visits at the time for the second dose. So again, great process. Again, how can we make things work easier? And there's enough that providers have to do. And so any way that we can try to make that easier would be great. Mustafa, do you want any other questions?
I would say, this is probably a question to Dr. Deming. From your experience, do you feel the patients, they ask about HPV vaccine after the fact they end up with cancer? And the main reason why I'm mentioning this, I remember with some infections before, like pneumococcal infection. Unfortunately, those patients, when they had pneumococcal infection, the family was asking, well, we heard about pneumococcal vaccine, for example. That was years ago before PCV, once PCV was in the market. So if you can elaborate to us about that.
Yes. Sometimes I do get asked about it. Again, the two most common cancers that we see are cervix cancer in women and oropharynx cancer in men. Occasionally, you'll have a young patient in her 20s with cervix cancer. Now, a young patient in her 20s would have had the opportunity to have had the vaccine. But if they haven't had the vaccine, there are opportunities to get vaccinated later in life. And I apologize, as I'm not someone who gives vaccines, but over the years, the age at which you could give a vaccine has gone up. But once you have the cancer, giving the vaccine is not going to be useful in that particular patient's cancer. So It's the opportunity to prevent the most cancers comes when boys and girls are vaccinated in their preteens and early teens. That's the best opportunity for vaccination.
Sure. I see some questions on the chat. I'm going to start with this one. The question is, do you have your parents sign the consent for your vaccines? Usually, yes. And if they send the patient, let's say, 16 and older, for example, they may drive themselves. We try to always make sure, I would say from practical standpoint, we try to make sure the parent is aware about the vaccine. We have a few instances, I would say, the parent may want it and the kid doesn't want it. That's easy. But there's the one that the kid wants it and the parent does not. We try to always have some reasoning with the parent. So if I have, let's say, a 16 or 17-year-old who's coming and said, I want the vaccine, but my parents don't. I'm like, yes, you have a choice, but we try to maintain good relationship with the parents. And luckily for those of you, I would say, situations, we were able to convince the parents by saying, you know what, your young child is going to be like a young adult soon, and they are trying to make good choices about their health. So probably I would give them some freedom to make good choice. And luckily, we have good luck with that. Anybody wants to say anything about that part, about parents signing the consent for the vaccine? I will move to the next one. The question is about, do the attendees here still see some hesitancy with this vaccine, or the COVID vaccine is the new bad one? I think that's a great question. The HPV vaccine, before COVID epidemic, I think it was relatively the bad vaccine, like we have to convince families about. Now the COVID, probably we have to discuss more in depth. I think part of it with the COVID, you're right, people probably got distracted with the COVID. I am seeing less hesitancy or resistance about the HPV, but I think mostly because the public now, they learned more about it. They hear about it probably at school, they hear about it on TV, social media. So I saw some advertisements on TV about HPV, to be honest with you. So I think that increased the awareness of families. I don't know if Dr. McCoy, Dr. Deming have anything to say about that.
Yeah, I probably agree. I mean, I think I would agree. It's probably more COVID than that. I don't know. Good, Laura. I think you have a great question with Dick. I know you mentioned a little bit about vaccinating at older ages, and I know there has been increased ages. And I don't think we have a good sense if what insurance covers at what age and what insurance company and all that. So I totally agree with you, Laura. I think I can circle back with our payers here at Mercy One to help you out. But I guess I would be interested if any of the folks on the call have found anything about that. Because yeah, I really have no clue which insurance companies would cover it. I think the majority would, but again,
and I think the same problem with, kids, especially seeing adults like infrequently trying to even I'm hesitating with, something like a Cologuard test, because something kicks back on that one patient that if I give it to them and they're hesitant if it's going to be covered, like a lot of times that's the factor. And if it's not covered, getting them to come back. But then usually, I mean, I had like a 29-year-old who was really, worried, and she was like, okay, like she was really motivated, to come back, and she did call her insurance. But I feel like that extra step, sometimes we can't, know. And I just didn't know how other people approach it, or if they've had much success getting older patients, vaccinated.
I can mention one thing about it. The vaccine is recommended universally through age 26. So 27 and through 45, there's what they call the shared decision-making process. So I would say probably those are the patients that maybe we can ask the patient, can you call your insurance company to see if they allow it? So they don't get the cost as a private, out of pocket.
Sure.
Yeah, Laura, I can circle back with our billers and see kind of what we're seeing here in central Iowa, but I guess I would be interested if anybody on the call has any experience with that.
There is a nice, I would say, question or statement here, like about hesitant girls and their mothers, in knowing that there are many girls are victims of date rape. I don't know if anybody want to elaborate more about that.
Mustafa, this is Dick, and I don't want to elaborate about that, but I think I see several comments, and it would appear to me that one of the best strategies is not to focus on the sexual relationships, but on preventing cancer. And as many of the comments have pointed out, cancer is a big, scary disease that, kills 600,000 individuals in the United States. And to have something as simple as a vaccination to prevent cancer, that leading with that, and I defer to you guys as primary care docs because I don't vaccinate individuals, but it would seem that individuals knowing that the reason we're doing the vaccination is to prevent cancer is a very strong piece of information that can influence parents and children in making a decision to become vaccinated.
And you are very right. I think that's one of the messages we always try to tell families, like this particular vaccine is to prevent cancer, because most of the time the families are focusing on vaccines to prevent infections, like direct infection, where they talk about whooping cough or talking about mumps, measles, rubella, things like that. But this one, you're right, the message has to go direct, like we're preventing cancer as the ultimate goal.
I kind of wonder if the primary care docs, even though we don't say this and nobody says this, but the relationship with HPV and sexual activity, whether some parents think, well, this is a vaccine to prevent STDs, and, sort of miss the big picture that it's a vaccination to prevent cancer.
That's very true. And I can add a personal story about it. I remember when the vaccine was new, one of the dads brought the teenager and he told me, can we give her the sex vaccine? So my nurse told me about it before I went to the room. I thought I couldn't really understand what she meant. But when I went to the room, the dad said it again. So I tried to explain to him, this is number one, the vaccine is not to encourage young ones to have sexual activity at early age. Number two, it has nothing to do with the STD as a indication. It's primarily about like cancer prevention.
Yeah.
So thank you, Dr. Deming, for emphasizing to us the importance about the cancer prevention part.
Yep. I see a question here. If the most common age of oropharynx cancer is 60, what recommendations should be given to older men with risk factors? So I'm not sure if I understand the question exactly. Sort of the peak age is 60. Certainly, I've seen oropharynx cancer in men in their 40s, so it does happen even younger. In terms of the other risk factors that I spoke about were tobacco consumption and alcohol consumption, and so those should be part of just how to reduce risk of cancer. Is you don't smoke. You moderate your alcohol consumption, you get daily physical exercise, you maintain a normal body weight, you eat nutritious foods, you watch for sun exposure. Those are sort of classic things one can do to reduce the risk of getting cancer in general. With the oropharynx cancer, again, it's the alcohol consumption and cigarette smoking. So cigarettes don't just cause lung cancer, they cause many other types of cancer, including oropharynx cancer. But I don't know if the question was intended to, at what point do you continue to vaccinate individuals, after the age of 27 to 46? I don't know the science. I know that it is allowed, and probably you're going to get the most effectiveness in preventing cancers if individuals have not yet been sexually active and intend to become sexually active. But that would be a reason to maybe consider vaccinating at an older age. But I have to admit, I don't know the science on which individuals over the age of 27 are most benefited by getting a vaccine at that age.
There's another question, Dr. Deming, maybe you can touch on, which is about women diagnosed with cervical cancer more likely to develop other HPV cancers.
Great question. I suspect they are, especially the vulvar and vaginal, that if you already have a HPV cancer caused by one of the strains of HPV that causes cancer, that the risk would go up, but I don't know the data on that directly. So I apologize, I can't answer with evidence.
There is a nice statement here about, working in a surgical floor specializing in oropharyngeal cancer, and the emphasis on continuing oral healthcare. I think that's a very nice message that everybody needs to see the dentist. I know myself, when I go to the dentist, they check my mouth to tell me like there's no obvious lesion they can see. So that's a very good statement. There is this here about running into issues with school administrators keep telling us the HPV is controversial. I think we need to have more education to the society in general. Like people need to learn more about the HPV infection and the complications, which is basically the cancer part. I think this is the part that we need to educate on our end, whether a physician or a nurse practitioner or a PA or a nurse, anybody involved in the Department of Public Health, anywhere, we have to keep pushing the message to the schools to educate everybody. You know what? It's 6:32. It's a great, gathering. I just would like